Hello, everyone. Welcome to the first episode of the Shoulders Up podcast, where we break down complex vestibular and headache disorders. I'm your host, Dr. Jimmy Pang, physical therapist helping people reclaim their lives from dizziness, vertigo, and headaches. So, with this being the first episode, I just wanted to take some time today to introduce what this podcast is all about and explain the framework that I currently have for treating my patients. Where did this concept of shoulders up come from? So, like I mentioned, my practice is primarily built around complex cases involving dizziness, vertigo, headaches, or a combination of all three. So, I think the first thing that we have to establish is we have to understand that dizziness, vertigo, headaches, these are not disorders in themselves. These are actually symptoms that come up with certain disorders. So I'll give you a couple examples. So a disorder that causes dizziness or vertigo, we can think about BPPV, right? The most common cause of vertigo. If we think about headaches, we can think about primary headache disorders like migraine, or maybe they're more orthopedic in nature, right? Cervicogenic headache that is being referred from the neck. And then, of course, we have disorders that fall in the middle. And classically, the one that we would think of the most is probably vestibular migraine. So, vestibular migraine, for those of you who don't know, it is a migraine variant that comes with episodes of severe vertigo for most people. And so, while there are conditions that fall right in the middle, I would say that the way our healthcare industry is currently set up is that it still sees these two branches as two distinct specialties. So you have one column where, people are really specialized and really good at treating dizziness and vertigo. And then on the other side, you have people who are really well versed in treating headaches. And this makes a lot of sense if you look at how studies are done. In studies, we have very controlled settings, we control for all the variables. And invariably, what we're looking at is just how do these treatment interventions apply specifically towards the population that we're looking at. But that's not the real world. The real world is very different. Oftentimes, with these cases, you're going to see that they have presentations that kind of blur the diagnostic lines. They're going to have kind of strange or bizarre vertiginous symptoms and headache symptoms, and they don't fit neatly into any diagnostic criteria that we have. And this is a problem because in healthcare, we are, well, societally and financially incentivized to silo ourselves into deep specialties. So you often hear people say, I'm a vestibular therapist. I focus on vestibular disorders. And then you'll have people say, I'm a headache PT. And a lot of times there's a strong emphasis that their primary modality is for treating the neck to help resolve the patient's headaches. But most of these patients are actually going to come in with a mix of both. I often see cases where they actually need intervention both from the orthopedic side and the vestibular side. So we're kind of looking at everything at once. But going beyond that, I wanted to introduce this concept of shoulders up because I think there are actually more systems, even more systems that are involved. So everything I'm saying, I'm sure already makes sense to a lot of people. I'm sure some people are already thinking, well, yeah, that's what I do, right? But as we start looking into more complex disorders, it gets, well, more complex. So I'm thinking of the various systems, physiological systems that are involved. So I think today what I'll do is I will just kind of talk through the various systems that I think we should think about. I think I'll start with things that are probably most familiar to us physical therapists. And then as I go down the list, we're going to touch on other specialties, other things that we really need to consider when we see these complex patients with headaches or dizziness. And a lot of this is also driven by my own experience. So I'll be sure to share some of that as well. So let's start with the basics. Let's talk about cervical contributions to headaches or dizziness. So your head sits on your neck, and if your neck does not know where it is in space, that can cause some dizziness, right? That makes sense. So yeah, if your neck's proprioception is impaired and you don't know where your neck is in space, your brain doesn't have reliable information in regards to where your head is in space, and the result it can create is dizziness. Now, interestingly enough, when you have neck pain or if there's dysfunction, especially in the upper cervical segments, the pain, a lot of times, yes, you'll have it in the neck, but the pain also refers up into the head, often in what we call a ram horn distribution. So it kind of wraps up the back of your head and then comes up over to the front. And so what happens with people who have dizziness or vertigo is that they don't like movement. They don't like moving their head or their neck. They don't like turning their head. And what happens is that can result in stiffness. And then with the stiffness, that's going to feed further back into any cervical dysfunction that might have been there or might cause some cervical dysfunction. And when that happens, that leads to more headaches and dizziness. As PTs, even if you are a vestibular specialist, I think all of us have a fair amount of skills in treating necks orthopedically. I mean, we've all have our doctorates now and we've all been to school for 6 to 7 years. And I would say that physical therapy school, for the most part, is still very heavily weighted towards orthopedics. So I think a lot of us already have that skill set to treat cervical disorders. So moving on, what else do we think about as physical therapists? And so I want to get into vestibular systems. So this might be outside the comfort zone for a lot of PTs, but if you're going to work in this population, obviously you need to be very familiar with vestibular disorders. You need to understand how we treat these disorders, and we need to know, how our evaluation, our examination, and our treatments are going to look like. So quick refresher. When we're talking about vestibular disorders, we're generally talking about the function of the inner ear and how that inner ear function integrates with your brain function. So we have these inner ear organs. Our balance organs are in our inner ears. A lot of people, they know about this. They know, okay, our ears have something to do with our balance. But when you kind of dig a little deeper and you ask them, well, how does it help with your balance? A lot of people draw blanks. People don't really understand exactly how that works. So a quick overview is that you can think of your inner ear balance organs as their main job is to provide your brain with information on where your head is in space relative to gravity. So you can think of them as two little gyroscopes on in your inner ears on both sides of your head, and they're constantly receiving information about how your head is moving in space, where your head is in space relative to gravity, and that's really going to help you spit out your sense of equilibrium. So what happens with certain inner ear disorders is that if we think about something like BPPV, right, that means one ear is getting stimulated more than the other ear. And this discrepancy tricks your brain into thinking that your head is moving. And when your brain is being tricked like that, what happens is that we get a pathological eye movement called a nystagmus. So that's what we're thinking about in vestibular disorders. We think a lot about the function of the inner ear, how well the inner ear is working. But sometimes, in certain conditions, the inner ear is actually fine. And what we have is we have a software problem where the brain is not integrating the information coming from your inner ear correctly. And when that happens, that can also lead to obviously dizziness and vertigo. Generally speaking, disorders that purely affect the inner ear tend to be more intense. They tend to be more intense. So BPPV is quite intense. Vestibular hypofunction is quite intense. But at the same time, these we call them peripheral disorders. For the most part, they are easier to treat. People make much better gains. They have much better chance of full recoveries. So with BPPV, the average time it takes to resolve this problem for people is 1.2 sessions. And oftentimes it's as little as just one session, one and done. And then for conditions like a vestibular hypofunction, that's a lot more disabling. But generally speaking, it can be resolved with 6 weeks of structured, targeted vestibular rehabilitation. Compare this to some more central disorders like UPD or vestibular migraine. These people, it can certainly be intense, but generally speaking, they don't typically come with balance issues that are so severe that they'd really risk a fall. Functionally speaking, they are probably more capable of getting through their day, but they live with this constant sense of dizziness, vertigo, or fear that an episode may come on, especially in the case of vestibular migraine. And those are just a few examples of what we see. All these different disorders, they have very different treatment trajectories. And as a vestibular therapist, that's what we really want to be thinking about. And so the next one is jaw pain. Jaw pain, headaches, and neck pain are very, very much interrelated. They are, I would even say, interdependent. So obviously everything's connected. Your whole body is connected. But I think oftentimes what we start seeing is people start making some claims that they make claims that I think are stretching a little bit. An example I can give you is someone has a headache, right? And they come in and they tell me that their previous provider told them they have a headache because they have a leg length discrepancy of half an inch and their hips aren't aligned and it's traveling all the way up the chain to their head. I'm generally not really in agreement with that line of thinking. I just don't think it's true. I don't think we have enough evidence to really support that. But when we look at the jaw and the neck and the head, that's a very different system. There are very clear biomechanical interactions between these three regions that impact how you feel. So let's try to break it down a little bit. So first of all, let's talk about the neck and the shoulders. So the neck muscles are very interesting in that they cross multiple joints. So or a lot of the muscles that attach to the base of your skull, a lot of them will connect from the neck, but then also a lot of them are muscles that cross multiple joints. So I'm thinking of muscles like your upper trapezius that actually connects to your shoulder blade or your scapula. So already we're starting to see some examples of regional interdependence from the shoulders up. Your shoulder and your neck and attachments to the head are all very much involved. And then, so how does that translate into jaw pain? Why are we looking at the head and the neck and even the shoulder when it comes to jaw pain? And the reason we have to look into that is even though the jaw muscles are generally just straight from your mandible, your jawbone, to your skull, what happens is in order for your jaw to move up and down properly without your head moving around all the time, what happens is you need your head to be stable, right? But your head is kind of translated in front. Gravity wants to pull it down. So unless you want to be eating and headbanging at the same time, those neck muscles really need to be strong and coordinated properly in order for your jaw to function properly. When you open and close your jaw, it actually puts some strain on your neck. It wants to pull your neck forward, and your neck needs to be strong enough to counterbalance that so that you can chew your food properly. And so we end up with this chicken or an egg situation, right? Is the neck issues at the neck causing the headaches and also causing jaw pain? Or is it being built backwards from the jaw and that's causing headaches? And then that's also leading down the chain into some neck pain. And like I mentioned, the regional interdependence between these structures is very well established, and it's much more plausible than claims that say a leg length discrepancy leading to tinnitus or headaches. These are all things I've heard from my patients being told by other providers. And then what's especially interesting, and this applies to pretty much every disorder we've talked about, vestibular, cervical, what we also want to think about is where's the jaw joint located? So the jaw joint, a lot of people guess they kind of point somewhere to just under their cheekbone. That's where they think a lot of times their jaw pain is. But actually, the jaw joint is actually pretty high up, and it's actually closer to right in front of your inner ear. Our joints are innervated with nerves. And so a lot of the nerves that are innervated in this area with your jaw joint, they come very close. They come very close to the nerves that innervate the ear. And this is really important because a common complaint that we hear with jaw pain is that we also hear about tinnitus and dizziness. And that's because these neural structures are so close that if there's a lot of noise kind of in one, that noise can really push into these other sets of nerves in that same area. So already we're starting to see how jaw pain, headaches, neck pain, vestibular dysfunction, they all share neurological pathways that are very close to one another, and they can feed into one another, creating a vicious loop. And oftentimes we'll see our patients, some of the ones who are more severe, they will present with a lot of these different things going on. And so our job as therapists is to really figure out which is the true source of all this. Is it truly just all coming from one source, chicken or egg situation? Are there multiple systems involved? How do we prioritize? How do we prioritize? And that's really going to be based on the history and our physical examination. So moving on, we're still staying in the realm of what we see as physical therapists, but we're starting to venture out just a little bit. And so what I want to talk about next is ocular motor dysfunction, or thinking about vision. So let's start off first by talking about vision, distinguishing between sight and vision, because there's a very big difference between sight and vision. Sight, when I think about sight, I'm talking about the structural integrity of your eye. How is your eye doing? Are there cataracts in there? Like, is there any kind of degeneration in there? Is there something wrong with the optic nerve? We're thinking about hardware issues. Your eyes are essentially two cameras. Compare that to vision. Vision is very different. So vision is really an output of how your brain processes the visual information that is coming through your eyes. So let's think about it. We have two cameras. We have two eyes, right? We have two eyes. I think most of us probably haven't opened our third eye yet. So we all have two eyes and essentially have two cameras. So when we look at something, we're actually taking two separate distinct pictures. Each eye is taking a picture. And then those pictures are then sent to your brain, and then it's your brain job to merge the pictures together so that you aren't seeing double all the time. That's really what vision is. Vision is more of a software output. It's taking this visual information from the outside and processing it in a way that makes sense to us. And what makes it really interesting is that actually the image that gets reflected in your eye, it is actually upside down. And then your brain takes that image and flips it right side up. That's how vision works. And a lot of our patients who present, especially concussion, they're going to present with visual complaints. They have trouble reading. They have trouble looking at a computer screen. They might feel disoriented in busy environments or even open spaces in instances of something like a divergence insufficiency. So how do we go about treating vision if we see something wrong? So as physical therapists, we're mostly focused on ocular motor dysfunction. And ocular motor is just a really fancy way of saying how your eyes move. So let's talk about convergence, for example. We now live in a society with very high convergence demands. We're practically always on computers, on screens, looking at things that are pretty close to us. And what you need to be able to do is that your eyes need to be able to come together well in the same direction as you would be when you're going cross-eyed. Your eyes need to be able to come together well so that you can do these objects at a closer distance. So your eye movements need to be coordinated coming in. And what we see sometimes, especially after a concussion, is that they develop something called a convergence insufficiency. Their eyes don't come together well. And the following result is abnormal diplopia, or they might see double, or it might cause them headaches. There are other eye processes like saccades or smooth pursuits. These are also things that we address in physical therapy. Some examples you can think of for convergence insufficiency might be something like a 3-dot card or a Brock string. But vision runs much deeper than just how the eyes are moving. Are they tracking things well? Are they moving together well? There's a lot more to it than that. How did that whole visual system develop over age? Are there any resting misalignments in the eye? I think as most physical therapists, vestibular therapists, we don't really have any tools under our belt to truly treat that. We have very crude measures for measuring convergence insufficiency. The main tool we use is near point of convergence. So bringing a finger or pencil as close as you can to the patient's nose, asking them to keep their focus on that pen or finger and letting us know when they see double. When we do that, anything more than 6 centimeters is considered it's a little more rare, but there are also instances where people are going to present with something called a divergence insufficiency, meaning that their eyes tend to come in too much. They're having trouble kind of getting their eyes pointed straight ahead, separating them, creating a little distance between the eyes. And we call that a divergence insufficiency. And as physical therapists, we don't have any, at least not that I know, we don't really have any tools that we can objectively measure that with. A lot of it is really based on what we hear from the patient. Clues that we might get is especially feeling disoriented in open spaces or having trouble looking at things in the distance, or maybe everything in the distance is really clear, but they notice when they look in the distance, such as when they're driving, it gives them headaches or pressure in the head. This is an example of divergence insufficiency, and we can treat it to some degree, but our methods are pretty crude. I would say our methods are actually pretty crude. Talking about more eye movements, there's also something called accommodation. So accommodation, we're kind of looking again your eye as a camera. And when you look at objects up close versus when you look at objects far away, right? The aperture of the camera has to get bigger or smaller. And that's a process called accommodation. And that's something us as physical therapists, we also work with a little bit, primarily through, near far focus exercises. Examples might include something like a heart chart, right? I'm a really big fan of using a heart chart. But again, similar to divergence insufficiency, us as PTs, we do not have any objective measures for truly measuring how much, what is wrong with the accommodation. Can we put an objective number to it to explain exactly just how off it is? So where do we go from there, right? If we have a patient come in and they're presenting with a lot of visual symptoms and we're really truly unclear on what to do, or we feel like we have these really crude techniques that we're using, but they're not making the progress we want, where do we send them to? And the answer is that you want to send them to vision therapists. Vision therapy is actually pretty unknown among physical therapists. So when I bring up the term vision therapy, oftentimes people will automatically go to OT. OT. The vision therapy I'm talking about is very, very different from OT. So vision therapists, they are or they work under specialized optometrists. So these optometrists, I know they used to be called FCOVD, so Fellow of College of Optometry of Vision Development. Anyways, very niche field. I hope I got that acronym right. I know they recently just rebranded because FCOVD was reminding people of COVID too much. So now I think their acronym is FVODR. I'd have to look it up, what it stands for. Hopefully I got the letters in the right order. But if you have people who are really complaining a lot about these visual symptoms and you feel like you've kind of done what you can and you think these people need a little more, that is who you want to send them to. You want to send them to vision therapists who are or work under an FCOVD. And so I have personal experience with vision therapy. I am a migraine patient, and I would say that going to 12 weeks of vision therapy was probably the best decision I've ever made. And I've been a physical therapist for 8 years, and I had never even heard of this specialty until 3 or 4 years ago when I decided to go into vestibular. So even now, when I talk to neurological physical therapists, they aren't necessarily see a lot of vestibular cases, but even some of them, actually, I would say a lot of them aren't aware of this specialized field of vision therapy. So we talked about measurement, how physical therapy objective measures for vision deficits are quite crude, but it's very different when you go to one of these vision therapy offices. So a lot of us have been to a standard optometrist, right, where they're trying to get the right prescription for your vision to see well with glasses. And you know that thing that they kind of put in front of your eyes and they kind of flip a little thing, they go 1 or 2, which one's clear? Take that and take it to a whole nother level when you go see one of these FCOVDs or these vision development optometrists. So they have devices that look very similar, but instead of maybe just like one's clear, one's not clear, they'll do things like you put the lenses in front of your eyes and then all of a sudden you're seeing double. You're seeing two of everything. And they move things closer together. They want you to tell them when you see one, when you see two, all these really, really cool tests and that are actually quite trippy, in my opinion, if you don't have any experience in this realm. Definitely consider that. I think if you are a vestibular therapist, especially, it's really worth connecting with a vision therapist. There's tons and tons of overlap. And by collaborating, you're ensuring the best outcomes for your patients. Those are the things that I think are truly under our PT belt. We have a lot of tools to deal with these things. Obviously, when we got to vision rehab, we are still able to handle some, but not quite as well as these more niche specialists. So let's start talking about some other areas that we see in these patient populations that we need to consider. Let's start with so a lot of these patients, they're going to be reporting complaints of brain fog, right? Problems with executive functioning. These are very, very common issues. Actually, as PTs, I think we can work a little bit with cognition again with very, very crude measures. So we could use, dual cog tasking, we could use certain memory tasks, short-term memory tasks interspersed through our physical therapy session. We can work on cognition somewhat, but obviously we're not going to have as deep as an understanding of a neuropsychologist. So I think if you're someone who works in the vestibular world or the headache world, or if you're like me and you try to straddle both, then you definitely want to be in contact with a neuropsychologist for sure. And then another piece that we need to consider is that with a lot of these headache or dizziness slash vertigo disorders, a lot of them are also going to present with certain autonomic dysfunctions. This is especially true in migraine. I see this all the time in migraine. And, people are familiar with some of the more intense autonomic dysfunctions. I'm thinking of things like POTS or dysautonomia, these very largely systemic forms of a dysregulated nervous system, dysregulated autonomics. But I think when you work in these populations, we really need to be thinking about the autonomics of the shoulders up, the autonomic functions in the head, neck, and face. With central neurological disorders like migraine, what we're going to see oftentimes is we're going to see a lot of cranial nerve involvement. A lot of cranial nerve involvement, which also leads to a lot of autonomic symptoms that come up. So, examples I'm thinking of are things like eye tearing, right? Your tear glands, that's an autonomic function in the head. I'm also thinking of sinus congestion, right? Maybe your sinuses, you feel kind of stuffy. This is also largely an output of autonomic functions. And they're starting to think that actually, if you look at people who get diagnosed with sinus headaches, they're saying now that as much as 80 to 90% of those cases, their headaches might have been actually migrainous in nature, but their headache disorder is accompanied by congestion, right? And sometimes they don't even have a headache, but they have these really intense sensations of congestion. And that could actually be more attributed to possibly a migraine disorder, right? That we have an hyperactive nervous system that is causing symptoms like congestion, runny nose, eye tearing. We also want to be thinking about things like ptosis. So for me, when my headaches get pretty bad, I should preface this by saying that I've actually had a headache for 6 years. Yeah, I'm a complex headache case. I've been through pretty much all the therapies we just talked about, cervical, jaw pain, vestibular, vision. I've done all of it. Okay. But kind of going back to this autonomic dysfunction, what you're going to start seeing is that a lot of these patients, like me, are going to present with symptoms of, their nose and throat. Nose and throat. So I think ENT, having a good ENT on your team is highly underrated. Very, very underrated. I think that's one of the most underutilized professions when it comes to migraine management. We also know that histamine has a big role to actually play in managing dizziness, vertigo, or headaches. So, a lot of you are probably familiar with the medication meclizine, right? Meclizine is often used to treat dizziness or vertigo. And surprise, surprise, meclizine is actually an antihistamine. So I'm not saying if you have dizziness or vertigo that you can just go see an ENT and all your problems are solved and all you got to do is take an antihistamine, go buy tons of Benadryl and take that. Do not do that. Okay. Do not do that. If you have a migraine, if you're a migraine patient, your first priority should probably just be a neurologist. See a neurologist. Okay. And then after that, definitely start adding these adjunct therapies because they're going to make a big difference. But if you don't have a neurologist on your team and your migraine is really, really uncontrolled, it becomes very difficult for these physical therapies, vision therapy, even ENT for us to do proper work and make a big difference. And so, like earlier, I talked about how a lot of these headache disorders, they can also cause, they generally speaking, some of them have a lot of cranial nerve involvement. and that includes the glossopharyngeal nerve. So, a lot of times, patients who have migraine, they have headaches, they have dizziness, they might have trouble. They might have trouble with speech. They might have trouble with talking, right? And that can actually be for multiple reasons. Actually, common but not so talked about symptom of migraine, especially in the aura period, is problems speaking. Almost like aphasia, not quite, but with the brain fog, right? They're having trouble stringing words together, having trouble talking. And then on top of that, if you have actual glossopharyngeal involvement, especially the motor distributions, then what's going to happen is that talking becomes physically difficult as well. So, not just mentally difficult, but also physically difficult. So, this is when we also want to be thinking about speech language pathology, having a speech language pathologist on your team. Now, believe it or not, I know I sound completely normal, but this actually happened to me. So I had, become a chronic migraine patient about 6 years ago. And then 2, 3 years down the line, all of a sudden, I had difficulty talking for really long periods. Even now, I feel a little pain in my throat during this podcast, speaking for a lengthy amount of time. So I actually have also been going to speech therapy. And so these are some of the things that I think we don't really think about as physical therapists. I think everyone is just so focused on their specialty. The neurologist is looking at medication management. The PT that they might be seeing is purely focused on the neck. If they're lucky, maybe they get referred to vision therapy if that's indicated and they're doing vision therapy. And then our patients will come up with things like, well, I'm having this really bizarre symptom. I'm having trouble talking. I'm coughing a lot. And a lot of times, patients, what happens is it gets dismissed because these symptoms aren't things that we were trained to expect. We weren't trained to expect. So a lot of times we go, that's not me. That's not my specialty. You need to go see someone else. Right. And that's fine. Sometimes, it's out of your wheelhouse. But I think it's really important that we give patients this context. Why is this happening? Versus just throwing up our hands, being like, I don't know what's happening at all. I just focus on the neck. I just focus on the neck. And if you're having like weird voice symptoms, difficulty talking, I just look at the neck. I don't really know. And then obviously you would refer to the speech pathology. Compare that to, well, actually, with migraine disorders or central neurological disorders, it can have a lot of impact on the cranial nerves. And so when that happens, it can lead to motor deficits in your voice box and in your larynx. So I think the person you should see is a speech language pathologist. So all of a sudden now, your patient is not freaking out thinking about, is this something new that's coming on? They have a framework and much better guidance for pursuing these different specialties. And what happens is we see obviously a mix. Everybody comes in with their own unique mix. And so that's when you and the patient have to kind of brainstorm together and game plan together, try to really figure out how do we prioritize, what should we focus on, because not everybody can juggle 5 or 6 appointments. And then I think as therapists, we really need to keep honing our skills. Obviously, we want to be very specialized, very focused on maybe something that we're really good at, but we cannot stop thinking like generalists. We have to remain a generalist, especially if you're looking at these disorders. On some level, you need to understand the neck, you need to understand the vestibular system, you need to understand the jaw, you need to understand ocular motor dysfunction. We need to understand how these disorders that we treat lead into other more abstract symptoms, such as facial pain or tinnitus or, problems speaking, laryngeal symptoms, autonomics, ENT symptoms. We need to have an understanding. And even if we aren't equipped to train, oh, and I forgot to mention executive functioning, but if we aren't trained to expect these things, then we're not providing our patients with the best education. And we know education is really, really important for empowering our patients. And so that's where the concept of shoulders up comes from. When I say shoulders up, I'm not just talking about musculoskeletal issues. I'm thinking along these lines of, you know, ENT, speech, executive functioning, or ear disorders, right? And I'm really hoping that as this podcast expands, I can take on guests who understand these functions well. I would love to speak to a speech language pathologist. I would love to speak to a neurologist. I would love to speak to an ENT, a neurootologist, right? This is another specialty that I think a lot of people aren't aware of. Physicians straddle this space in between neurology and ear dysfunction, right? I'd love to have someone like that. And then also thinking about a lot of our patients have facial pain. And sometimes that facial pain can also come with facial weakness. And when we see that, all of a sudden we also need to be thinking about facial rehab, which is a very, very niche field. And I'm really trying hard to meet more people who are in this space and learn more about this. Obviously, that's a lot to juggle for one person. You don't have to be good at everything, but you do need to know the basics a little bit about everything. So even if you do refer out, maybe you can get them started with something small. Just give the patient a sense that they have some control of their situation and that there is a path forward for them. So we just covered a lot. We covered some stuff that we are really good as PTs, and then some of the other professionals that we need to keep in our orbit and other symptoms that we should really be looking out for. Not just thinking in diagnostic boxes, not just thinking about the systems that we treat, but taking a more bird's eye view and thinking about the physiological processes, not just musculoskeletal, not just vestibular, not just neurological, all of them, how the physiological processes of the head and neck above the shoulders interact. I think that'll be it today. Hopefully, everything I went over, it's a lot of information, but hopefully it all makes sense. And we're starting to get an idea of how all these systems are integrated and how, as therapists or as patients, we need to be thinking along these lines, understanding that a lot of these complex disorders will come up with bizarre symptoms, but these bizarre symptoms aren't necessarily unexpected and they aren't things that we can't address. We can definitely address them. So I think I will leave it there. If you want to find out more about me, you can check out my website at pangphysicaltherapy.com. You can also find me on Instagram at pangphysicaltherapy.